Hey everyone. So you're likely looking to get a solid understanding of something really important, that
Yeah.
connection between addiction and trauma, especially uh, how it shows up within our justice system.
Hmm.
And you want to know what really matters without getting, lost in the weeds of endless research papers.
Exactly. Just the key information, clear and concise.
Well, that's exactly what we're diving into today.
And we've looked at two really helpful sets of information for this. First, there's an overview from Tikva Lake, Florida, that gives us a good sense of the big picture on addiction and trauma stats and general treatment approaches.
Okay.
And second, we've pulled insights from the SAM HSA library. They focus specifically on screening and assessment for people in the justice system who are dealing with both mental health and substance use issues, what we call co-occurring disorders, or
Right,
CIDs.
CIDs. So our goal here, it's pretty straightforward, really. We want to unpack how addiction and trauma are tangled together.
Understand just how common this is, particularly when the justice system gets involved.
Yeah, and get a handle on how professionals actually figure out what kind of help someone needs. Think of it as getting informed, quickly but thoroughly.
Sounds good.
Okay, so let's start right there with
Yeah.
that core connection. Addiction and trauma.
Mm.
Just how often do these two things actually go together?
Well, it's really striking. The frequency is very high. It's actually quite unusual to find one without the other having some kind of influence. They seem deeply intertwined.
Right, and like the sources explain, it often works something like this. Someone goes through something deeply traumatic.
Yeah.
It could be abuse, neglect, maybe witnessing violence,
Yeah, really damaging experience.
and it leaves these significant emotional, mental scars.
Exactly. And for some people, maybe quite a lot of people, using substances or, engaging in addictive behaviors becomes a way to manage that intense pain.
Ah, yeah.
It can be a way to kind of numb those difficult feelings or the memories tied to the trauma. It's like a form of self-medication in a way.
That really shows you how deep that connection can run. And this isn't just like anecdotal observation, is it? There's actual data showing how often this happens.
Oh, absolutely. The research is quite clear here. Studies indicate that a really significant majority, we're talking up to 75% of individuals who are seeking treatment for addiction, have also experienced some form of trauma.
Wow, 75%, 3 out of 4 people.
Mm-hmm. It's a very high number.
That really underscores how huge this issue is.
Mm-hmm.
And understanding numbers like that, as the Tikva Lake info points out, it isn't just about statistics, is it? It tells us something about the real impact on people, families, whole communities.
Definitely. Grasping the prevalence helps us see the scale, identify patterns, maybe risk factors, and figure out where we need to focus intervention and support.
So what does a rate that high, that 75%, tell us about how we should maybe be thinking about addiction itself?
Well, that high percentage strongly suggests that for many, many individuals, trauma might be a really significant underlying driver of their addiction. It really points to the need for treatment approaches that don't just focus on the substance use in isolation. You have to acknowledge and address the past trauma too.
Makes sense.
And it might also suggest that, our systems could perhaps do a better job at identifying and addressing trauma earlier on, maybe even preventing some pathways to addiction in the first place.
That makes a lot of sense. Okay, so when someone is dealing with both addiction and trauma, what are the typical kinds of treatment that might be offered? What's out there?
There are several common approaches. You have inpatient rehabilitation, which provides a very structured, intensive environment. People get individual and group therapy, often some holistic approaches too.
Okay, like living there for a period.
Exactly. Then there are outpatient programs. These offer more flexibility so individuals can attend counseling and therapy while, still living at home and managing daily life.
And therapy itself, just, talking one-on-one with a professional, that's got to be a huge part of it.
Absolutely. Individual therapy is often crucial. It helps people explore the root causes, develop healthier coping strategies, and really work towards recovery.
Right.
And there's also medication-assisted treatment, EMAT.
Imaging, okay.
These are specific medications like methadone, buprenorphine, naltrexone. They can help manage withdrawal symptoms and cravings.
Make it easier to engage in therapy.
Exactly. It makes it easier to focus on the therapy and other recovery work. And these are always, prescribed and carefully monitored by medical professionals.
And what about the support you get from other people going through it? That seems really valuable too.
It absolutely is.
Yeah.
Support groups like Alcoholics Anonymous, Narcotics Anonymous,
Yeah.
AA, NA. They provide a really vital network. People
Hmm.
can share their own experiences, get guidance, and importantly, connect with peers who genuinely understand what they're facing.
That peer support element sounds critical.
Hmm.
Okay, now let's shift gears a bit and focus on the justice system specifically. The SAM-HSA information we looked at really hammered home that co-occurring disorders, these COSEs, are a major concern in that context. Why is that?
Well, the prevalence is just very high. The number of individuals involved in the justice system who have both mental health and substance use disorders is significantly elevated compared to the general population.
So it's much more common there.
Much more common, and this makes it absolutely essential to have good systems for screening and assessing people for both types of disorders right when they enter the justice system.
And trauma. That seems to be a big factor here too, doesn't it? It keeps coming up.
Yes, absolutely. The rates of trauma exposure, things like physical abuse, sexual abuse, are also disproportionately high among offenders.
Okay.
Because of this, the SAM-HSA source strongly suggests considering universal trauma screening for this population. Some research really highlights this need. Understanding someone's trauma history can be just crucial for figuring out their path and what they need.
Yeah, it definitely makes sense. If such a large portion have experienced trauma, you have to know about it.
So beyond trauma, what else are these initial screenings in the justice system trying to identify?
Well, screening for suicide risk is critical. Unfortunately, rates of suicidal thoughts and behaviors are higher among individuals with CODs in the justice system.
That's really concerning.
It is. Also, understanding how motivated someone is for treatment is important. That motivation level can be a predictor of outcomes, and you can actually get a sense of it even at the screening stage.
Interesting. I also noticed drug testing was mentioned as part of screening. How does that fit in?
Right, drug testing.
Huh.
It can actually serve a couple of purposes. Beyond just detecting use, the knowledge that testing might happen can sometimes help increase a person's motivation for treatment and improve their adherence.
Ah, like an accountability factor?
Kind of, yeah. It
Yeah.
can be an incentive for some to reduce or stop their use. And research does suggest it can be a valuable tool in this setting.
And, it's really important to underscore that with any screening and assessment, being sensitive to cultural differences is key, and making sure the staff doing it are well trained to understand and navigate those differences.
Absolutely crucial. So screening is that first step, finding out who needs help. But it's obviously not the only step. How do we move from just identifying these issues to actually providing, effective help?
Right. That's where the idea of matching the treatment to the individual's specific needs really comes into play. There's a model called the Risk, Need, and Responsivity model, often just called RNR.
R&R.
It was developed by Andrews and Bonta, and it's being used more and more in justice settings. It's basically a framework to help identify someone's treatment and recovery needs, but specifically looking at them in relation to their risk of reoffending,
Yeah.
criminal recidivism.
Okay, so it's not just looking at their clinical diagnosis, like depression or
Mhm.
addiction, but also linking it to their risk of ending up back in the system. Why is that important?
Because the R&R model helps figure out the right level of both treatment and supervision for that person within the justice system. It specifically incorporates factors related to criminal risk things that might not typically be the focus of a standard mental health or addiction assessment.
Got it.
So it allows for a more tailored approach, trying to address both the factors contributing to criminal behavior and the underlying mental health and substance use issues simultaneously.
That sounds like a much more comprehensive way to think about it. But our sources also make it clear that dealing with co-occurring disorders, especially in this population, is really challenging.
Oh, extremely challenging. Individuals with CODs present significant hurdles across both the criminal justice and social service systems.
How so?
Well, for one, research indicates they just have a higher likelihood of being arrested compared to those with only one disorder or none.
Why is that?
Often, it's linked back to that self-medication idea we talked about. They might be using substances to try and alleviate symptoms of their mental disorders, things like trouble sleeping, depression, intense anxiety, maybe even feelings of paranoia.
They're trying to cope, but it backfires.
Exactly. While it's understandable, it can lead to more problems, including interactions with law enforcement.
And it sounds like they can get caught in a cycle.
That's a very common pattern. What you often see is individuals with CIs cycling rapidly through various systems: law enforcement, jails, hospital emergency rooms, homeless shelters.
Just bouncing between them.
Pretty much. And they frequently struggle with unemployment, homelessness, they often lack job skills, and have very limited financial or social support networks. All this instability just makes recovery incredibly difficult.
It paints a really tough picture of someone just trying to stay afloat.
It is, and sadly, for some individuals in that situation, the drug use itself, or even selling drugs, can unfortunately start to provide a kind of social connection, maybe a sense of structure, or even a distorted feel of purpose or meaning that's missing from other parts of their lives, like stable work or family connections.
Wow, that's complex.
It really is. These aren't simple issues with easy answers.
And it highlights that the relationship between the disorders isn't always straightforward, like one causing the other. They can be really tangled up.
That's a critical point. Alcohol and drugs can actually cause symptoms that look just like mental disorders, or they can mimic them.
Okay, so the substance use itself creates psychiatric symptoms.
It can, yes. That's why it's so incredibly important during an assessment to really dig into the timeline. You need to look closely at the history of someone's substance use and their mental health symptoms.
To figure out which came first.
Essentially, yes.
Yeah.
Did the mental health symptoms only appear after the substance use began? That might suggest the substance use is triggering or causing those symptoms.
Yeah.
But conversely, you also need to assess if the substance use started as an attempt to cope with pre-existing mental health symptoms, maybe trying to manage agitation, anxiety, depression, sleep problems.
This is like detective work.
It really is. To get an accurate diagnosis, professionals need to establish that timeline carefully. And importantly, they need to assess mental health symptoms during periods when the person is not using substances during abstinence.
To see the symptoms persist.
Exactly.
And
If the symptoms continue even when they're sober, it points more towards an independent mental health disorder. And of course, you always have to rule out whether any underlying medical conditions could be causing or contributing to the mental health symptoms.
it sounds like a really detailed investigation is needed to untangle all these threads. And the challenges aren't just within the individual. The systems themselves can sometimes create obstacles, can't they?
Absolutely. That's a major issue highlighted in the SAMHSA resource. There's often a lack of good communication and coordination between the folks working in behavioral health and those in the criminal justice system.
They speak different languages almost.
Sometimes, yeah. They might have different perspectives, different priorities, different ways of understanding and approaching COs. And a really significant problem is the scarcity of resources for people when they're trying to transition back into the community after incarceration or other justice involvement.
So help might stop at the jail door.
Too often, yes. That lack of follow-up treatment and support in the community can completely undermine any progress someone might have made while they were involved with the system. People fall through the cracks.
That really emphasizes the need for that thorough assessment you were talking about earlier to understand exactly what support someone needs.
Exactly. People with COs in the justice system are not a monolithic group. They're incredibly diverse.
How so?
Different types of disorders, different combinations, varying symptoms, different levels of impairment in their daily lives, different personal strengths, and crucially, different levels of risk for future criminal behavior.
So one size fits all definitely doesn't work.
Not at all. Comprehensive screening and assessment are absolutely vital because they allow us to match individuals to the services that are most appropriate for their specific situation.
Like what kind of services?
Well, it might mean referral to specialized courts, like drug courts or mental health courts, which are designed to handle these complex cases. Or it could mean different program tracks within a correctional facility, tailored to different needs.
So it's about getting them into the right pathway.
Precisely. There are tools to help with this. The Patient Placement Criteria, or PPC, developed by the American Society of Addiction Medicine, ASAM, is one model. It helps assess the severity of both the substance use and any co-occurring mental health issues across 6 key dimensions.
6 dimensions, okay.
Yeah, things like intoxication withdrawal risk, biomedical conditions, emotional behavioral conditions, readiness to change, relapse potential, and their recovery environment. This helps guide decisions about the right level and type of care.
That sounds helpful.
And we're also seeing more specialized responses emerging, like crisis stabilization units. These can offer immediate short-term care, often up to 23 hours for people experiencing a crisis related to their CIs. They provide triage, assessment, and referral to ongoing care.
Like an emergency room specifically for behavioral health crises.
Kind of, yeah. A more specialized and appropriate setting.
Okay. And where in the justice system are the best spots, the best opportunities for these screenings and assessments to actually happen?
There are several key intercept points, as they're sometimes called. Ideally, it starts very early, even with law enforcement. Things like crisis intervention teams, CIT training for officers, can help them recognize and respond appropriately to someone in a mental health or substance use crisis.
So diverting them from jail if possible.
That's often the goal, yes. And having those law enforcement-friendly crisis stabilization units available means officers have somewhere appropriate to take someone besides the emergency room or jail.
Makes sense. What about later stages?
Screening and assessment are incredibly important at the court level, particularly during the dispositional phase when decisions about sentencing or case outcomes are being made. Good assessment information can really help judges make more informed decisions.
And lawyers play a role.
Absolutely. Defense attorneys and specialized defender-based advocacy programs often play a vital role in gathering this kind of behavioral health information and presenting it to the court to advocate for appropriate treatment and support for their clients.
It sounds like getting that full picture early on can really make a difference in someone's trajectory through the system. What kind of specific information are professionals trying to gather during these more comprehensive assessments? It sounds like a lot.
It is a broad range, aiming for a holistic view. They look at family history, any mental health or substance use issues in the family, current medical status, any medications they're on, definitely trauma exposure past and present, social and family relationships, support systems or lack thereof, how they typically cope with stress, their interpersonal coping strategies. A detailed mental health history is crucial, including any past suicidal thoughts or attempts, symptoms of PTSD.
Right.
They might look at cognitive functioning, especially if there's suspicion of something like a traumatic brain injury. And of course, a very detailed substance use history. What substances, how often, how much, for how long, what have the consequences been?
So the specifics of the use.
Yes, plus practical things like reading and writing skills, any cultural or linguistic barriers that might affect communication or treatment. Importantly, they also look for individual strengths and supports what resources does the person have.
Focusing on assets, too, not just problems.
Exactly. Risk factors, yes, but also protective factors. What are their interests and skills? What do they actually expect from treatment and recovery? And, as we mentioned, assessing their motivation for change is a key piece, too.
Wow. That is a very thorough look at the whole person and their entire situation. It really goes beyond just a diagnosis.
It has to be effective.
Now, one model I've heard mentioned for bringing some of this together, particularly the screening and initial intervention part, is the SBIRT approach. Can you tell us a bit about that?
Yeah, SBIRT. It stands for Screening, Brief Intervention, and Referral to Treatment. It's designed as an integrated approach, often used in general healthcare settings, but also explored in other places.
How does it work?
Basically, it uses quick, evidence-based screening tools to identify people who might have risky substance use or potential substance use disorders early on.
Okay, the screening part.
Right. Then, based on the screening results, the BI brief intervention involves having a short conversation with the person. It's focused on raising their awareness about their substance use, exploring its connection to their health or other goals, and motivating them towards change.
Kind of like planting a seed.
Exactly. And then the RT referral to treatment is for those who screen at higher risk levels and need more intensive help. They're connected with specialized addiction treatment services.
So, does SBIRT work well in the justice system context, especially for folks with codones?
While the evidence is a bit mixed, SBIRT has shown promise in the general population for addressing risky substance use. However, our SAM-HSA source notes that more research is really needed to understand how effective it is specifically within justice settings, and particularly for the complexities faced by individuals with co-occurring disorders. It might be a useful tool, but maybe not the whole answer for this population.
Got it. Something else that seemed really important in the source material was the idea of looking beyond just the diagnosis at someone's actual functional impairment, how their issues affect their day-to-day life.
Absolutely, that's a critical point.
Yeah.
Sometimes how someone's cognitive and behavioral issues impact their ability to function, things like managing daily tasks, holding a job, maintaining relationships, can actually be a better predictor of how they'll do in treatment than just knowing their diagnostic label.
So the practical impact matters more than the label itself.
In many ways, yes, especially for treatment planning. And assessing functional impairment isn't always straightforward. It often requires observing someone's behavior in relevant settings, not just relying on self-report or checklists.
Yeah.
Understanding these functional impairments, alongside identifying their strengths, any skills deficits they might have, and considering any cultural barriers, is really key to developing treatment plans that are truly informed and likely to be effective.
That makes a lot of sense, tailoring it to their real-world challenges and abilities.
Mm.
Are there certain characteristics or patterns that researchers have commonly observed among people in the justice system who also have co-occurring disorders?
Yes, the literature does identify some common characteristics that tend to show up more often in this group. Things like a younger age when they first offended,
Yep.
a history that might include aggression or violence, often multiple prior incarcerations, and sometimes difficulty functioning independently even within the structured environment of a jail or prison setting.
So a pattern of earlier onset and more persistent difficulties.
That's often what the research suggests, yes. And these are important factors to be aware of when planning interventions and support.
Which again, it just points back to the complexity of their needs and the potential for getting stuck in that cycle of justice system involvement. Now, let's circle back to drug testing for a moment. It sounds like it plays a pretty significant role in this context.
It really does. The recommendation from our SAMHS source is pretty clear. Drug testing is crucial for virtually all justice-involved individuals who have co-occurring disorders. That includes people who are currently in jail or prison.
Why is it considered so essential?
Well, beyond the motivational aspect we discussed, it provides objective information about recent substance use, which, as we know, can be hard to get accurately just through self-report. For people considered at higher risk of relapse, maybe because of the severity of their CDs, past difficulty staying abstinent, frequent hospitalizations, or unstable housing, more frequent testing is usually advised.
How frequent?
It varies, but the idea is to tailor it to the risk. Ideally, testing should start as soon as someone enters the justice system and continue randomly but consistently throughout their supervision or treatment period.
Random seems key.
Yes, random testing has been shown to be more effective as a deterrent than predictable testing schedules.
Makes sense. What about the different types of tests? You mentioned confirming results.
Right. While quick point-of-care tests exist for any formal consequences or treatment decisions, it's generally best practice to confirm a positive result with a laboratory test. This is especially true for alternative methods like hair, sweat patch, or saliva tests.
But lab tests cost more, right?
They do, and that can be a barrier sometimes. Hair testing, for example, has advantages. It can detect use over a longer window, weeks or months, and it's hard to cheat. But there are cautions too. Concerns about potential environmental contamination affecting the results, and some studies have raised questions about potential racial bias, with certain hair types possibly retaining drug metabolites differently. So recommendations often include taking samples from the scalp and washing them properly before testing to minimize these issues.
Okay, good to know. And it seems pretty clear from what you said earlier that you really can't just rely on someone telling you whether they've used drugs or not.
That's very true, unfortunately. There are just so many reasons why self-report might not be accurate. Simple recall bias, forgetting details. Social desirability, wanting to present oneself in a better light.
Fear of consequences, obviously.
Absolutely. Fear of negative consequences. Demographic factors can play a role. The presence of mental disorders themselves, cognitive impairments, cultural norms around discussing substance use. It all complicates things.
So people might genuinely forget or intentionally downplay it.
Both happen, and studies consistently show that a substantial number of individuals who test positive for drugs actually deny recent use when asked directly.
So you definitely need more than just their word for it.
Exactly. That's why supplementing self-report with objective measures like drug testing and also gathering collateral information is so important.
Collateral information, you mean talking to other people?
Yes, getting input from family members, friends, employers, probation officers, treatment staff, people who know the individual and can provide another perspective on their substance use and overall functioning. Observing their behavior directly is also key. It helps build a more complete and accurate picture.
And what about digging deeper in the assessment itself?
Right, an extended assessment goes beyond just screening. It involves really assessing the significance and severity of the substance use disorder, getting a detailed longitudinal history, looking at patterns over time for both mental health symptoms and substance use.
They want to untangle that connection again.
Precisely. Analyzing the relationship between the mental health symptoms and the substance use, including understanding triggers for relapse, and then periodically reevaluating their risk level and symptoms over time because things change.
And other ways to boost accuracy.
Looking at archival records, past treatment records, criminal justice records can be very helpful. Waiting to do the assessment until the person is not acutely intoxicated or in withdrawal is obviously important for getting clearer information. And critically, understanding the psychometric properties, the reliability and validity of the specific screening and assessment tools being used. Not all tools are created equal.
Right, so once you have all this information from screening, assessment, testing, collateral sources, how do professionals then decide how much risk someone poses and how intensive their treatment or supervision needs to be?
This is where that R&R model comes back in strongly, particularly the risk principle. Identifying individuals who are both high risk for reoffending and high need in terms of their behavioral health issues is really crucial.
Why focus on the high-risk group?
Because research consistently shows that targeting interventions towards those at highest risk yields the best results in terms of reducing recidivism, future crime. Programs that effectively target high-risk offenders tend to reduce reoffending rates, and they also provide greater economic benefits to the community.
Okay. And how do they determine risk? You mentioned static and dynamic factors earlier.
Exactly. Risk assessment tools look at both. Static risk factors are historical things that can't be changed, like their age at first arrest or their criminal history. Dynamic risk factors, also called criminogenic needs, are things that can be changed through intervention and are directly linked to criminal behavior.
Like substance use.
Precisely. Substance use, antisocial attitudes or beliefs, lack of education or employment skills, problematic peer associations, those are key criminogenic needs.
And the R&R risk principle says.
It basically says that the intensity of the services provided should match the individual's level of assessed risk for recidivism. High-risk individuals need more intensive services and supervision.
And low-risk individuals.
They generally need less intensive intervention. In fact, there's a caution against placing low-risk offenders in high-intensity programs or settings,
Why is that?
because it can actually be counterproductive. It might disrupt their existing protective factors like stable employment or positive family ties, and it could expose them unnecessarily to negative influences from higher-risk peers.
So more isn't always better for everyone.
Correct. However, it's important to note that even if someone is assessed as low risk for criminal recidivism, if they have co-occurring disorders and are at risk of increased substance use or worsening mental health without treatment, then providing CO-DOSE treatment is still beneficial for them.
Got it. So it's about matching intensity for both criminal risk and clinical need, and supervision levels too.
Yes. Supervision should also be matched to risk. High-risk individuals benefit from more frequent, structured, and tailored supervision that specifically addresses those criminogenic needs we talked about: substance use, antisocial thinking, employment issues. Low-risk individuals require much less intensive supervision.
Okay, that makes sense. Now, within this group, particularly those at higher risk and with significant mental health issues, the risk of suicide looms large, doesn't it? You mentioned it earlier.
Tragically, yes, it's a very serious concern. National statistics show that over 90% of people who die by suicide have a history of a mental health disorder, with depression and substance use disorders being particularly common factors.
And it's even higher in the justice system.
Yes, the risk is significantly elevated. One study found that suicide attempts are 5 times more likely among incarcerated individuals who have mental disorders compared to those without.
5 times. Wow.
It highlights why ongoing suicide screening is absolutely critical for offenders with co-occurring disorders. The combination of serious mental illness and substance use significantly increases that risk.
So it's not a one-time check at intake.
Definitely not. Comprehensive and systematic suicide screening needs to happen repeatedly at different stages of justice system processing: arrest, booking, pretrial diversion, entering probation or parole. It's especially important during that first month of incarceration, which is a high-risk period, and also before significant events like court dates.
Who is considered at the absolute highest risk.
Research points to individuals with severe depression, those experiencing psychosis like in schizophrenia, and people going through acute drug withdrawal as being particularly vulnerable.
And what specifically are they assessing during the suicide screening?
They look at several key areas: current suicidal thoughts, how frequent, how intense, whether the person has a specific plan, how lethal that plan is perceived to be, have they taken any preparatory actions?
Like gathering means.
Exactly. They also assess the person's self-control, their ability to resist acting on suicidal impulses. Crucially, they also explore reasons for living. What protective factors does the person have? And what level of social support is available to them?
It's a stark reminder of the vulnerability here. Okay, shifting slightly, back to treatment engagement. It sounds like someone's motivation to change is important, but maybe not in the way we typically think about it. Like, do they have to want help to get help?
That's a great question, and there's a common misconception here. While it's true that someone's level of motivation can predict things like treatment compliance, dropout rates, and overall outcomes, low motivation is often linked to higher dropout. It's not true that high motivation is a necessary prerequisite for treatment to be effective.
So you don't have to wait for them to hit rock bottom or have some big epiphany.
No, not at all. In fact, the thinking has really shifted. Instead of seeing motivation as something a person either has or doesn't have, the focus is now on interventions that can build motivation and self-efficacy, their belief in their own ability to change.
Like motivational interviewing.
Exactly. Techniques like motivational interviewing are designed specifically to help people explore their own ambivalence about change and strengthen their commitment to pursuing positive goals. So a lack of initial motivation shouldn't be a barrier to offering treatment. Rather, treatment itself should include strategies to enhance motivation.
That's a really important distinction and a more hopeful perspective, actually.
It is.
Now, something else that's crucial, given the demographics of the justice system, is cultural factors. How are things like ethnicity, background, gender, sexual orientation considered in screening and assessment?
This is absolutely essential, and the SAMHS's source really emphasizes it. Because such a large proportion of individuals involved in the justice system come from minority backgrounds, it's critical to carefully consider the impact of ethnicity, social class, gender, sexual orientation, race, disability status, socioeconomic level, even religious and spiritual affiliation in all aspects: screening, assessment, and treatment planning.
Why is it so critical?
Because, unfortunately, being from a minority group can often act as a significant barrier to accessing and benefiting from treatment. Research shows that individuals from racial and ethnic minorities are often less likely to seek treatment in the first place. They tend to have lower rates of treatment completion and, sadly, sometimes higher rates of recidivism compared to majority groups.
What causes those disparities?
It's complex, likely involving systemic factors, historical distress, lack of culturally appropriate services, implicit bias, but also individual experiences of discrimination, shame, and social exclusion can really take a toll. They can lower a person's self-efficacy, their belief that they can succeed, and lead them to anticipate negative judgment from treatment staff, which makes them hesitant to engage fully.
So a culturally sensitive and competent approach isn't just, the right thing to do. It's actually fundamental to making interventions effective for everyone.
Absolutely fundamental. Without it, we risk perpetuating disparities and failing to meet the needs of a large segment of this population.
Okay. Now, you mentioned earlier that there isn't one single magic tool for screening for co-occurring disorders. So given that, what are some of the actual instruments or questionnaires that professionals use?
Right, because there isn't one specialized tool that perfectly captures all aspects of SOLDS, the common practice is to use a combination of different screening instruments.
Like a battery of tests.
Kind of, yeah. They'll often combine tools that screen for mental health issues, separate tools for substance use disorders, maybe specific ones for trauma or PTSD, and sometimes even tools to gauge motivation or readiness for change.
And this is used alongside drug testing and that collateral info.
Exactly. It's about putting together multiple pieces of information for the most accurate picture. Our SAMHSA source provides a really helpful guide, actually it was Figure 8 in their document, which lists recommended instruments for these different domains.
Can you give us some examples, like for mental disorders?
Sure. For screening for general mental disorders in justice settings, some recommended options include the Brief Jail Mental Health Screen, that's the BJMHS. There's also the Correctional Mental Health Screen, which has male and female versions, the CMHSF and CMHSM, and the Mental Health Screening Form 3, or MHSF3.
Okay. And for substance use, quick screens.
For brief substance use screening, they suggest tools like the Texas Christian University Drug Screen V, the TCU DSV, also the Simple Screening Instrument, or SSI, and the ASSIST, that's the Alcohol, Smoking, and Substance Involvement Screening Test.
And what about looking for both the co-occurring part?
There they often suggest using specific combinations. For instance, using the Menini screen, which looks at several psychiatric disorders.
Yeah.
Or pairing one of the mental health screens, like the BJMHS or the CMHS, with one of the substance use screens, like the TCU-DSV.
Combining forces, basically.
Exactly, to cover both bases efficiently.
What about assessing motivation?
For motivation and readiness for change, examples include the Texas Christian University Motivation Form, the TCU MOT Form, and the University of Rhode Island Change Assessment Scale, the Eureka-M.
And trauma. That seems really important given our earlier discussion.
Absolutely. For trauma history and potential PTSD, they recommend first screening for exposure to traumatic events using something like the Trauma History Screen, THS, or the Life Stressor Checklist Revised, LSCR, or the Life Events Checklist for DSM-5, LEC-5.
So just finding out if they experience trauma.
Yes, that's the first step. And then if trauma exposure is indicated, using a PTSD symptom measure like the PTSD checklist for DSM-5, the PCL-5.
Okay, a two-step process. And finally, suicide risk screening tools.
For suicide risk, the recommendations include combinations like the Interpersonal Needs Questionnaire, INQ, plus the Acquired Capability for Suicide Scale, ACSS, or standalone scales like the Beck Scale for Suicide Ideation, BSS, or the Adult Suicidal Ideation Questionnaire, ASIQ.
That's a pretty comprehensive list of tools across different areas.
Mm-hmm.
And the source material also gave some sense of how well some of these actually work, or the pros and cons, right?
It did, yeah. It didn't go into exhaustive detail on every single one, but it provided some useful insights. For instance, one study mentioned found that the MHSF Air and another tool called the GAME-SS showed slightly higher overall accuracy and sensitivity in detecting mental disorders compared to the MI&I screen, although all performed adequately for identifying the most severe mental illnesses like bipolar disorder or schizophrenia.
Good to know.
It also noted the time commitment assessment instruments generally take about 45 to 90 minutes, while full diagnostic interviews can take up to 2 hours.
That's a significant amount of time.
It is. And it reiterated the point that substance use screens can be vulnerable to manipulation or minimization, which again highlights why combining them with drug testing is important.
Right. Any highlights for specific substance use tools?
Well, the ASSIST was noted for screening a wide range of substances, including guidance for brief intervention and having good validation internationally. The ODD-8 is widely used and effective for identifying alcohol problems, especially current ones, and it's freely available.
Free is always good.
Definitely. The TCU-DSV was highlighted for good reliability and validity, with high agreement between self-report and interviews. So the overall recommendation for substance use screening in justice settings often boils down to using the TCU-DSV, or the SSI, or the ODD-8, or the ASSIST.
Okay, a few solid options there. And what about for mental health screening specifically in this challenging setting?
Well, the report stressed again that mental disorders often go completely undetected in justice settings without formal screening, leading to really negative consequences for individuals and the system.
So screening is essential.
Absolutely. In terms of specific tools, the BDI-2 was mentioned as widely used and good for diagnosing depression, even among those with substance use problems. The CESD is another free tool for current depression symptoms with good properties.
And the ones designed more for justice settings.
Right. The BJMHS got positive mentions. It's public domain, brief, easy to use, tested in forensic populations, and effective for identifying severe mental disorders. The K6 is another brief public domain screen that's shown good results across diverse populations, including offenders. And the MHSF3 also showed adequate performance in detecting mental disorders among prisoners in studies. So the recommended mental health screens often include the BJMHS, the CMHS-FM, the MHSF3, or the K6.
Got it. And quickly, any standouts for trauma or suicide risk tools mentioned?
For suicide risk, the BSS was noted as being able to discriminate different levels of suicidal ideation among offenders. For trauma and PTSD, the PCL-5 is a standard measure. The TSC-40 was mentioned as a public domain tool used with offenders, including those with CODS, showing links to trauma exposure. The THS is a free, short screen just for identifying traumatic event exposure. Again, that figure 8 in the source is the best place for the full list of recommendations in these areas.
And the key point about motivation screens.
Just to reiterate, they shouldn't be used as a gatekeeper to treatment. The focus should always be on interventions that build motivation and self-efficacy, using tools like the TCU MOT form or Eureka M to track progress, perhaps, but not to exclude anyone.
That's really clear. Okay, this has been incredibly informative, a really deep dive into a complex area. So just to wrap things up, what are the most important things for us, for you listening, to take away from all this?
I think the key insights really boil down to a few core points. First, that incredibly strong, often intertwined connection between addiction and trauma. You often can't effectively address one without addressing the other.
Right.
Second, the significant challenges that co-occurring disorders present within the justice system, leading to cycles of involvement and instability for many individuals. Third, the absolute necessity of comprehensive, culturally sensitive screening and assessment processes to accurately identify these co-occurring issues early on.
Can't help if you don't know what's going on.
Exactly. Fourth, the importance of matching treatment and supervision approaches to the individual's specific needs, considering both their clinical issues and their criminal risk factors, like the R&R model suggests.
Tailoring the response.
Yes. Fifth, the critical need to be constantly aware of and assessing for the heightened risk of suicide in this vulnerable population.
A vital safety net.
And finally, understanding that while motivation is helpful, our efforts should really focus on building someone's belief in their ability to change and actively fostering their motivation for recovery rather than waiting for it to appear spontaneously.
It's clear that really understanding these complexities, all these interconnected pieces, is the absolutely essential first step towards developing more effective interventions and providing better support for individuals who are facing these immense co-occurring challenges.
Exactly. And perhaps that brings us to a final thought for you to consider. Something to mull over after listening. Given everything we've discussed, the high rates of trauma among people struggling with addiction, and especially within the justice system, how might things change if we adopted a more universally trauma-informed approach? Not just in specific treatment programs, but across all our systems: healthcare, justice, education, social services. What impact could that have on prevention, on intervention, and ultimately on long-term recovery outcomes?
That's a really powerful question. Thinking about what a truly trauma-informed system might look like. Definitely something to ponder and maybe explore further.